Among the vasopressors, noradrenaline is the first choice for raising MAP to a target value that is more than 65. If shock is not resolving quickly, further hemodynamic assessment can be done to check for the cardiac function, like stroke volume and stroke volume index. To determine the type of shock, clinical examination does not lead to the diagnosis. We can use the adjuncts like echocardiography and other biochemical tests. So, vasoactive agent management, use norepinephrine or noradrenaline as the first line of vasopressor. Target a MAP of more than 65. Consider invasive monitoring of arterial BP. If needed or indicated, we can have an arterial line introduced and can have continuously monitor the arterial blood pressure. If central access is not yet available, we can initiate the vasopressors peripherally, and once central access is available, we can shift to that. If MAP is inadequate despite low to moderate norepinephrine, we can add vasopressin as a second line agent or vasoactive management. If cardiac dysfunction with persistent hyperperfusion is present, despite adequate volume status and blood pressure, consider adding dobutamine or switching to epinephrine. So these are the choice of agents like norepinephrine, epinephrine, and vasopressin. Lactate, we have discussed about measuring lactate as a 1 hour bundle for us, which can help us guide to the resuscitation. That is why after the fluid therapy, we are measuring the lactate again to see whether there is lactate clearance or not. It is a marker of tissue hypoperfusion. So whenever hypoperfusion will be there will be increase in the lactate level because of the anaerobic metabolism leading to lactic acidosis. Guiding resuscitation to normalize lactate, and aim is to achieve a lactate level of less than 2.